Can I start? Hello.
Sir,
They'll do the introduction, sir, first.
Oh, introduction. I thought I can talk.
We are live.
Yes, sir.
Yes, Ramya has to talk about me, something like that.
Good evening, everybody. A very happy new year to all of you. Today we have with us none other than Professor Dr. V.R. Vijayaraghavan, sir. I consider it my privilege that he is my mentor. And I think everybody in the field of ophthalmology has been his student, is his student, and will be his student. So whomever I have come across, everybody has been sir's student at some point in their life. So I'm very, very fortunate to have Vijayaraghavan sir's blessings and guidance in my life. So today I'm extremely elated and glad that we are starting this new year with an ophthalmology session by such a stalwart in the field itself. So I'm deeply grateful to you, sir. We'll have a formal introduction of you by Pallavi. Over to Pallavi.
hello, everyone. Welcome to today's special session, Rendezvous with Retina and TackleTheTumours, Retinoblastoma. The White Army is privileged to have the legend himself, Professor Dr. V.R. Vijayaraghavan, sir, with us as our mentor today. Sir completed his MBBS in 1976 from Stanley Medical College, DO from Madras Medical College, and MS Ophthalmology from Stanley Medical College. He has FRCS. He has got his FRCS in 2000, and he has served as a medical officer in the Army Medical Corps from November 1977 to February 1983. He has served as a postgraduate teacher in various institutes in Tamil Nadu and government medical colleges for 30 years and retired as professor and HOD of ophthalmology from Coimbatore Medical College. Sir is presently serving as the academic director and consultant at Arasan Eye Hospital and Postgraduate Institute in Erode, Tamil Nadu, and is a visiting postgraduate teacher at various eye hospitals. We are honored to have you with us today, sir. A very warm welcome to you.
Thank you, Pallavi. I must thank Ramya for this great opportunity because I was not knowing about all these things. She only told me, she just told me, then I told, because I served in army, I must also serve in this White Army also. So the actual army I saw about from I think more than 40, nearly 40 years over. So let me see another White Army for another few more years. I think that will be a pleasure for me. If you invite me for so many lectures and even for the complete your UG course, some other topics which may not understand, like retina and something like this, we have got cornea and all, we can talk, nothing wrong. First, I will tell you something about
Sir,
tumors.
it is our pleasure, sir. It is our pleasure, sir, that you have accepted our invite and are willing to be a part of this group, sir. Thank you so much. Thank you so much, sir.
Hello, this is my duty to help our own children. That's the most
Yes,
important
sir.
thing. I consider all my students as my own children. So
Yes,
naturally,
sir.
they will come up in life. At least,
Yes,
if
sir.
you see somewhere after 10 years, somewhere me, you will tell no so and so. At least you will recognize me. That's enough.
Yes, sir. Yes, sir. Definitely.
Sanja?
Yes, sir.
Moreover,
Yes,
you will give
sir.
me free treatment also. I hope so. Understand now?
Yes, sir. Yes, sir.
Hey, life is like that, man. Understand now? It will be very pleasure to see our own students in after 15, 16. You know that I visited US about 10 years back. I was in Atlanta airport and suddenly one fellow came, sir, how are you, sir? I totally got forgotten about his name. Then he got himself introduced. Sir, I was your student in 1989. Like that he was telling. So I was very happy to see that. I will follow. And fortunately, what happened? He took me to his house. I stayed there in his house for 4 days. The problem is what? I saved 4 days hotel charges. Understand now? That's the importance. Follow in way this way, mutual. Okay. I'm very happy. At the same time, so many things happen in life. I'll tell you a few points as far as I will tell you few points for MBBS level, then few points for your NEET exams, so that it can help you to face some NEET exam also in the future. There are some statements you are supposed to know in the exams. I'll tell you. Of course, these are all my prayers. My face is sideways. Hello. This sideways photo. See now, if you're asked the exams, the most common primary intraocular tumor in children. Never forget that word, children. Retinoblastoma. Retinoblastoma is the most common intraocular primary. Never forget, primary in children. Another question is there, which is the most common primary intraocular? No age is mentioned. No age is mentioned, nothing. Your answer should be like this, melanoma choroid. That means it's the most common primary. Never forget this. Suppose the next sentence is what? I have not told now, I'm not telling primary and all. The most common intraocular. I will follow this point. Kunj.
Yes, sir. Yes, sir.
The most common intraocular. I'm not telling primary and all. Your answer should be secondaries in the choroid. So children, primary retinoblastoma. Primary intraocular, no age is mentioned, melanoma choroid. Most common intraocular is melanoma. There are secondaries in choroid. The primary sites, breast tumors in females, and your answer is bronchogenic in males. These are all common MCQs for your NEET exams. Okay. Now I'll take you to, it's also one statement you're supposed to know. You should not ask. The most common primary intraorbital rhabdomyosarcoma in children. Rhabdomyosarcoma is the most common primary orbital in children. This normally they will not ask these things. Understand now? See now here. You have written now. Can you see this? Forget me not. You know this? What is forget me not? Kunj, you know what is forget me
sir.
not?
It's a flower.
It's a flower which.
Can you see downwards? Hello, I put a picture of the flower only.
Yes, sir. Yes, sir.
Yes,
You
sir,
know the
yes, sir.
story behind it?
No, sir.
You don't know the story. The beautiful story, of course, it will take over 1 minute extra. See, one king and Raja and Rani, you know Raja Rani?
Yes, sir.
King and queen were walking along the banks of a river. The river was flowing in full flow. And these flowers and all actually growing in shady areas. They are looking very nice. And they were in the river. Rani, that queen wanted, hey, amko ye flower chahiye. Let me get some flowers. This flower went inside the river. Samjha? Then
Yes,
he was washed away. And he was catching the flower, is washed away. That time he was shouting, hey, queen, don't forget me, don't forget me, forget me not, forget me. That's the story. Understand now?
Oh, yes.
Follow.
Yes, sir.
Samjha? That fellow shouting, the king was shouting, forget me not, forget me not. That's the name. This flower has got the name because of that.
Okay.
All right,
Yes.
follow.
Yes.
Similarly, I'll tell you how the retinoblastoma is shouting from inside. Understand now?
Okay. Yes.
Hey, retinoblastoma is inside the that retinoblastoma is shouting, please forget me not. I'm here. I'm here. He's going to shout like this. I'll tell you. Okay. Now we see. This is a retinoblastoma. You can see now. Of course, I will start here. Inheritance. Usually about, suppose imagine now you have got 100 patients of retinoblastoma. 40% will have hereditary patterns, hereditary mutations, whereas 60% is non-hereditary. Is an MCQ for you, for MCQ, hello, MCQ for your NEET.
Yes.
All right, follow?
Yes,
in that
sir.
40% hereditary is there, no 40% hereditary pattern is there. Only 6 or 7% only will be family history. Even though it's hereditary pattern, family history only seen about 7%. MCQ again. See, 40, 60 over. Among the 40%, you take the entire hereditary pattern fellows. Family history will be seen only half or hardly 7%. That means remaining fellows will not tell you. Others, that means parents will not tell you. But follow, they may not know also. That means what? Some mutation has occurred in the sperm or ova. That's all. Before fertilization. I didn't follow his point. Is not present the mother or father. Some mutation has occurred in the sperm or ova before fertilization. That is what hereditary patterns. But follow his point. Kunj.
Yes, sir.
Yes, sir.
Samajh gaya?
Sir.
Now what is this? I tell you, inheritance. If at all inheritance there, it is called autosomal dominant with incomplete penetrance. You know the meaning here? Autosomal dominant. That's all I tell you. That means you got 50% chance is there for a child to get.
Yes.
You know, we have got 100. You know this crossings and all. You know the genetic that you know how to draw. So 50%. Whereas in this case of incomplete penetrance, only 40 to 45% chance is there. That means some problem. So it is not manifesting in everyone. I don't follow. Only 45% chance. That is called incomplete penetrance. Never forget MCQ again. Retinoblastoma inheritance is autosomal dominant with incomplete penetrance. Never forget this word. That means the chances in the child about 45% in the case of hereditary patterns. Next, I told you, most of them I told you sporadic. Okay, 60% is sporadic. See, I'll tell you, what is the gene? That is called retinoblastoma 1. The gene is there. This gene is what? It is a tumor suppressor gene. That is present in all of us.
Yes.
Where? In the 13th long arm chromosome 14 location, 13q14 MCQ. A retinoblastoma gene is present in 13q14 location. That is a tumor suppressor gene. If it is there, tumor will not come. If it is not there, problem starts. That means what's happening in this patient? Inactivated or deleted. This gene is deleted, inactivated. The problem starts for the child. This what's happening in these patients. This is also MCQ for you. Understand now? Which is the chromosome number? They will ask you. Couldn't understood?
Yes, sir.
Pallaviji.
Yes, sir. Yes,
Pallaviji,
sir.
samjha?
Yes, sir. Yes, sir. Got
Bhul
it, sir.
jayega?
No, sir. Will not forget.
Kabhi bhulna nahi. Samjha?
Yes, sir.
Till you write your entrance exams and PG over. Otherwise, you can come to ophthalmology also after PG.
Yes, sir.
We'll be happy to see you. Hello.
Yes,
Kunj?
sir. Yes, sir. Sure.
Yes, sir.
Now,
Yes, sir.
next exam question for you MCQs. Knudson hypothesis. See, exam question is what? Now they will ask you in future exams. Knudson hypothesis is what for? This hypothesis mainly for which tumor they will ask you. Your answer is retinoblastoma. Finished. Knudson hypothesis means if you're asking exam, you close your eye and put the retinoblastomas, nothing else. You know what's the meaning here? Knudson hypothesis is 2 hits. You must have studied in pathology. 2 hits. What's happening now? One sperm ova is there. A mutation occurred before fertilization. That means what? Sperm got, imagine now sperm got mutated. This mutated sperm joins with ova. Now fertilization taken place. What happens now? After fertilization, the mutated sperm cells can go everywhere in the body. They can go to retina, they can go to bone, they can go to pineal body, everywhere they can go. That means what? Second mutation going to occur. That's called second hit. In the retina, retinoblastomas. In the retina, second hit, retinoblastoma occurs. But remember now, this fellow has got already a mutated cell in so many parts of the body. That means what? Second mutation in the bones, osteogenic sarcomas. Or one more mutation, pineal body tumors. That is what importance now. Hereditary pattern is there. Understand now? If you think it's a hereditary pattern, you have given treatment for the retinoblastoma patient, agreed. But the most important is this fellow has to be followed throughout his life, because the chance of developing second malignancy is very, very, very high. Sometimes that is the reason why do you want to know hereditary patterns. Number 2 is what now? Why do you want to know hereditary pattern? One more thing I tell you. It is also MCQ for you. Regarding treatment with radiotherapy. See, I have given retinoblastoma radiotherapy. I have decided about radiotherapy from outside. External beam radiations. You know, we have got one instrument called linear accelerator. Never forget, it's also MCQ for you. Linear accelerator is the machine that can be used to deliver your external radiations. Imagine now, he's a hereditary pattern fellow. You have decided on a hereditary pattern. You want to give radiotherapy. What will happen now? We are giving to the eye, but it can affect your bones around the eye in the orbit. I told you what? A mutated cell may be there in the bones also. Because radiation-induced mutation, they can develop tumor in the orbit also. Kunj?
Yes, sir. Yes, sir.
It's a classical MCQ. Doctor, retinoblastoma patient is there. When you give radiotherapy, what's the problem you expect in the patient if it's a hereditary pattern? Your answer is, sir, it can develop malignancy around the orbit. Chapter close. Kunj, if you answer this, you get what? Distinction. You may get what? Whichever subject you want. MD, radio, who knows?
Yes.
Samjha? Oi.
Yes, sir.
This is the most important. Knudson hypothesis ke kya matlab hai? Means these are, because you should know hereditary pattern means be careful about the treatment modality and also be careful about follow-up. Don't leave the patient. You give treatment, limb. Suppose it's a non-hereditary, imagine non-hereditary. You know what do you mean by that? Sperm over normal. All are fertilized. First mutation occurring in the retina. Second also in the retina, retinoblastomas. Now I given treatment. I have to follow him at least up to 6 years because recurrence can occur before 6 years only. Afterwards, normal recurrence will not occur. That means what's the meaning now? If I think it's a case of non-hereditary, I have given treatment to the fellow. And imagine I've cured him. But I can follow him for maximum of 6 years of age. Then I can forget about him. Because the chance of second malignancy is remote. As far as this mutation is concerned, that's now. Hello. You can have some other malignancy, not concerned with this area. Samjha Kunch?
Yes, sir.
So far, any problem? Hello, are you able to follow me? Sumant?
Yes, sir. Yes, sir.
Yes, sir.
Sumantu, Pallavi?
Yes, sir. Yes, sir.
Pallavi, are you able to follow me?
Yes, sir. Able to follow, sir.
Any problem, tell me so that I can go slightly slow.
Yes, sir. Sure,
This fast is okay.
Yes, sir. Yes,
Yes,
sir.
sir. Yes,
Fine,
sir.
sir.
But otherwise, I can repeat. Keep on repeating the same thing. Understand now? Don't worry.
No, sir. This is
That's
fine,
why I
sir.
repeat, man. Kunch, I normally repeat the same thing. You know why? Sometimes you are sitting there, but your mind will be somewhere roaming around in your place.
Yes.
Then suddenly that you would have missed it. Again, I come back and tell you. You will listen something. Kunch,
Yes.
sir, you will follow me? Definite?
Yes. Yes, sir. So just one doubt. So
Yeah.
in non-hereditary cause, the first state would be after the fertilization of the.
Before fertilization, everything is okay.
Okay, sir.
First thing mutation occurring in the retina, but retinoblastomas.
Okay, sir.
But you know that mutation occurring in this 13q whatever thing you are telling now, that is may not be in other areas. Understand now? So that's why non-hereditary patterns, if you are after giving treatment, you can follow him for up to maximum 6 years of age, because unless the recurrence has to occur, if at all, it has to occur before 6 years.
Okay, sir.
Afterwards, recurrence also remote chance. That is why you can afford to tell him, hey, you need not follow also. But better option, you can tell always come. That doesn't matter. But it is technically speaking.
Okay. So how do we come to know whether the patient is a hereditary cause or
That means you
non-hereditary
have to go
cause?
what? Kunj, tell me now. You have to go to sperm and ask her, hello. Or
Yes.
you go to OVA and ask her.
Yes.
That is the question next time I'm going to ask you. But you have asked me this question. Samjha?
Yes.
Kunjwala? Kunj?
Yes. Yes, sir.
I'll tell you very simple. Very, very simple. Remember I told you. Now we see this slide. Can you see this slide?
Yes, sir.
Clinically, how to identify hereditary or not. Samajh gaya?
Yes, sir. Yes, sir.
Hey, I'm hearing my sound, right? I'm hearing my own sound. Tell me. My sound is coming back. Doesn't matter. Now it's okay.
Sir, for us, it's okay, sir.
Okay. Not problem. Kunj, now
Yes,
see.
sir.
Here is one tumor. Can you see this?
Yes, sir.
Remaining, assume that other parts of retina is okay. And other eye also normal. That means I have to examine the child with the pupil dilated, with indirect ophthalmoscope, ultrasound, everything I have to do. Then only I can come to a conclusion. Now I come to a conclusion, sir, right eye problem, single tumor is there, sir. Remaining left eye is normal, sir. And your third eye also normal, sir. Kunje, your third eye also normal. Your fourth eye also normal. Which is third eye?
Pineal gland.
Third eye is pineal body. Because developmentally all are same neural ectodermal structures. Fourth eye is what? Parachiasmatic areas. That's all the neural ectodermal structures. If I got a problem there, that means pineal body, I'm telling you both eyes plus pineal body, trilateral retinoblastomas. Suppose I got right eye, left eye, pineal body plus parachiasma. I call it as quadrilateral retinoblastomas. Understand now?
Yes, sir.
But I'll tell you how to approach this clinically hereditary non-hereditary. Patient has come and I dilated. Now I see unilateral solitary. It is non-hereditary. Never forget. Whereas unilateral multiple, can you see this? Multiple tumors.
Yes, sir.
Hey, one
Yes,
point,
sir.
you may tell me, hey sir, here one tumor said it can be spread. It can tell you like this. It can be solitary spreading. Who knows? But your answer, never forget, retinoblastoma is one tumor which has got multicentric origin. If I got 10 tumors, all are individual tumors, not spread. That means what? Unilateral, multiple, hereditary. Tell me. Kunj, understood?
Yes, sir.
Next, if I got a bilateral, like this, one eye here, another eye here, always hereditary. Never forget this. And you see now, here in this case, can you see here? Say one eye, can you see one eye? And second eye, see the pineal body area. Can you see this? Trilateral.
Yes, sir.
Hereditary
Yes, sir.
again.
Yes, sir.
So what is non-hereditary? Only one condition, unilateral solitary. Remaining things are all unilateral, multiple, bilateral, trilateral, quadrilateral, all are non-hereditary patterns, hereditary patterns. You know, I told you what for I told you, to follow up the patient and also to decide about the radiotherapy role.
Yes, sir.
It's the way you can come to a conclusion. Understand now?
Yes, sir. Clear, sir.
Samjha Kunju?
Yes, sir. All clear, sir.
Pallavi ji?
Yes, sir. Yes, sir. Understood, sir.
Now I'll tell you another MCQs for international exams. Hello, international. Suppose you want to apply for PLAB, ECFMG. Hello, that what is that? What the USMLE and all nonsense. You have to know all these things. Kunj?
Yes, sir.
Now question is what they will ask. Okay, doctor, retinoblastoma you're told, child you're told. Which is the most common manifestation of retinoblastoma? They will ask you. Most common. Your answer is white people. Koreana people. Korea means people. Leucona, white. White people is a commonest man. Leukokorea, 60% over. Suppose a man having 100 cases, man, 60 cases, he will like leukokorea, manifesting as. Samjha?
Yes, sir.
That means the most common manifestation retinoblastoma is leukokorea, one MCQ. Next example. Now, can you see leukokorea? Can you see here? Hello?
Yes, sir. Yes, sir.
Yes, sir.
Oi. You know me the meaning of you know oi? Kunj.
No, sir.
Leukokorea. Can you see this?
Yeah.
Now we see. Leukokorea. Can you see this?
Yes, sir.
This is
Yes,
the
sir.
most common manifestation, 60%. Next, I tell you what happens now. This retinoblastoma, you know what is that? It is actually arising from primitive rods and cones. Rods and cones where they are on sensory retina from inner layer of the optic cup.
Yes.
The pigment table epithelium is from outer layer of optic cup. This is development.
Yes.
See, optic vesicle is there, invaginated to put a cup like this. A cup is like this. The inner layer forms a sensory retina. Outer layer forms a pigment epithelium of the retina. In this sensory retina, only you got rods, cones, everything is there. Other layers and all. That means you have to pass through my pupil, vitreous, you have to enter into the retina, go to posterior part, rods and cones. Stimulate it, then again coming anteriorly, come to my optic, now go into the brain. You are traveling in my yellow retina, hitting the rods and cones, coming back as an impulse, and go to my optic, now to my brain. I know Kunj is sitting there. That's all. Will you follow?
Yes, sir.
That means what? Rods and cones are the cells responsible for these tumors. Some aberration in the development, some genetic influence in the development, proper development, some it hinders the development, proper development, and go for tumor side. To follow?
Yes, sir.
Exam question is what? This retinoblastoma is arising from where? Your answer is, sir, primitive rods and cones, otherwise called photoreceptors. They are called photoreceptors. Photo means light. It's falling on the receptor site. Then only you can see the light, man. Could you understand?
Yes, sir. Fully.
Now we say rods and cones everywhere, you know, the retina throughout. So the tumor can arise from anywhere in the retina, you know, it can from anywhere. But sometimes, you know the point, sometimes, you see, I'm looking at you, man, Kunj. You are falling where? In my macula, the central portion of retina, central portion. You are falling in my macula, understand now?
Yes, sir.
Then only can see you. Suppose the tumor in my macula, I cannot see you. Almost will become like a blind eye. Understand now? You have to follow macula, man, fovea area, now, center part. Suppose the tumor is having rods and cones of that area, you cannot see. The vision is not there for the child. Now, the child will develop squint. Tell me. Squint.
Yes, sir.
Now we see squint. Can you see a squint, right eye? That's why whenever you see come across a patient of squint, In a child, be careful. Be careful. What careful? From inside, I told you, from inside, you retinoblastoma is shouting, hey, forget me not. Tell me.
Oh,
Forget me.
yes, sir.
Hey, convergence, classically convergent. That means eye is coming inwards. See, I'll tell you one thing. Normally, in old persons, when the blind eye is there, go for divergence. Just know this. Whereas in a child, go for, because the blind will go for convergence. You know the reason they will ask in exams. Your answer is the medial rectus in a child is very powerful compared to lateral rectus. That's why the medial is contracting and the eye is going for resting position. Resting position of a child is what? Convergence only in this child up to 2 or 3 years. Afterwards, you go for divergence. Understand now?
Okay. Yes.
The blind eye will go for convergence in a small child. The reason is medial rectus is very, very, very powerful. Now here what? 20% squint over. Manifesting as squint. That means what? 60 plus 20, 80% manifesting as leukocoria squint. This is what MCQ for you. Hey, they will ask you, man, the most common match with retinoblastoma is ABCD. Let that come, MCQ will be there. One leukocoria alone or one squint alone. Leukocoria plus squint alone. Understand? They can combinations. They can ask like this. You can tell C, you have to see. Hello, make a tick. Make a tick of C. Hello. Kunj, you'll get MB
Yes.
radio.
Yes.
You know why I'm telling you now? See, ophthalmology, ENT, all these things, smaller subjects. But the problem is what? You may get about 30, 40 questions. If you are able to answer these 30 questions and all, your rank will go somewhere.
Yes,
Somebody,
sir.
hey, medicine, surgery, OG, anybody can write. It's a final subjects. And anatomy, physiology, you have to read. No other go.
Yes.
When you are preparing for NEET. Because there's some sets up this man. Only final year means only 120 questions. First year, second year, up to second year, they got another something questions. Then third year, pre-final, they got some questions. And in third year, concentrate on preventive medicine, most important. Let them concentrate. All right, follow.
Yes, sir.
You are able to follow me. Any problem now so far, Pallavi?
No, sir. No problem, sir.
Sure.
Yes, sir. Yes, sir.
Now I'll tell you, these are all 80% over. The remaining patients, how they can manifest, I'll tell you. Remaining patients, how they can manifest. See now, a child is there. Imagine now a child, about 2 years old child, man. You know the cornea is there. Can you see the cornea? Is the cornea. The cornea adult normal dimension at birth is about 10.5 millimeters. Horizontally, you take the diameter, man. It's 10.5 at birth. For you, if I mention, for you, if I measure, it's about 12. That means what? That 12 is reached when? MCQ again. The adult dimension of cornea is reached when? Your answer is, hello, completed 2 years or starting point of 3 years. You can tell 3 years also, nothing wrong. Completion of third year, 2 years completed. That means third year starting. Or you can answer question, may I have 3 years also, nothing wrong. That means what? The cornea adult dimension is reached by completed 2 years or third year. Okay, that means what? A child is having a raised intraocular pressure because the tumor inside there is a space occupying. Within the eye, a tumor is there, naturally can increase the intraocular pressure. Now the cornea not yet reached the adult dimension. Something is a very soft structure now, they can easily expand. A diameter can increase. That is what the diameter cornea is increased. Ophthalmos case is an oxide. Oxide. Ophthalmos means oxide. Meaning. So ophthalmos has occurred. That means what? Kunj, by chance, you come across a patient of ophthalmos in a child. Hey, forget me not. Kunj.
Yes, sir. Retinoblastoma.
From inside, the shouting is there. If you forget and you see some, you all investigate, you are doing glaucoma surgery, the patient will die another next year. Will you follow?
Yes, sir. Yes, sir.
Patient may die where? He will go a vertical takeoff. You know that vertical takeoff? Straight to the upper world. Understand now? It's not horizontal. Hey, it's not horizontal takeoff. That means what? That is our mistake. That's why you must know, any child with a ophthalmos, a congenital glaucoma patient, if you think, can be congenital glaucoma, agreed. But never forget to rule out retinoblastomas. Dictum. Dictum. Understand now? Next one more point I'll tell you. See, can I have high FEMA? Can you see blood in the anterior chamber?
Yes, sir.
And you see now hypopion like these cells here. Can you see this? Hypopion, can you see this picture?
Yes, sir.
It will follow. Pallavi, can you see these pictures and all?
Yes, sir. Yes, sir.
Now we see hyphema, from where it can come. Your answer is because of retinoblastomas and all, because space occupying, hypoxia, so many things are there. They can develop a new vessel in the iris. New vessels can start the iris. They can bleed. But follow. That's why blood coming in the anterior chamber. What is then? What is hypopion? What is hypopion? You must have heard, at least hope so, third year. They would have told you.
Yes,
Pus
sir.
cells in anterior chamber.
Pus cells in anterior.
In uveitis and all corneal ulcer cases, you know that.
Yes, sir.
But here, it's not pus cells. It is a tumor cell. Tumor cells breaking from your main tumor, break and come to my anterior chamber, float. That is why it's called pseudo-hypopion. Tell me, pseudo-hypopion. Never forget this. Not follow. Hyphema is because of new vessels in the iris. Hypopion is because of retinoblastoma, because tumor cells occupying the anterior chamber. Finished. Next question. That's why, Kunj,
Yes, sir.
whenever you find hyphema in a child, hello,
Yes, sir.
unexplained hyphema, suppose no history of trauma, suppose child gets trauma, you know, hyphema will come, injury
Yes.
has occurred, there is no history, nothing is there, and you see hyphema, be careful, be careful. From inside, who is shouting?
Forget me not.
Hey, forget me not, my bloody fellow is coming from inside, retinoblastoma. Similarly, hypopion, see now hypopion, you think what's the case of uveitis? You think it's a case of uveitis, you need to start with. Now we are giving treatment for uveitis, no improvement. No improvement in hypopion, nothing. Be careful again, forget me not. Understand now? Don't
Yes.
follow?
Yes, sir. Fully.
Yes, sir.
That means what? These are all the various suspicions. They can manifest like this. Samjh gaya? Now we
Yes.
see. Now the beauty here, one important difference they can ask you in exams. Pseudohypopion is what I told you. Tumor cells are coming out. No, I told you. Now I am going to compare it with your another intraocular tumor. I told you. Most common primary. Melanoma cori, I told you. Any age, I told you. But usually adults, black people, white people, adults. It's more common in whites, not blacks. White. Okay. Now there the cells are very cohesive. Those cells from melanoma cori, they cannot break. They cannot come to anterior chamber. So pseudohypopion cannot occur in melanoma choroid. Whereas in this case, whenever I see a hypopion, be careful. Maybe that too in children, be careful. Suppose you come to PG level, no, he will ask you, why in retinoblastoma pseudohypopion, why not in melanoma choroid? He will ask in exams. You must also say the cohesive factor is very high, sir, in melanoma choroid, whereas it is very minimal, sir, because the tumor cells, they can easily break and come, sir, from primary tumor. That's all. Samjha?
Yes, sir.
Yes, sir.
Samajh gaya?
Yes, sir. Yes, sir.
See now one more. The tumor has come to the orbit. So far inside, it's come to orbit. That means what the problem? The eyeball can be pushed forwards. Or
Yes.
the tumor can undergo necrosis because the tumor increase in size, blood supply is cut off. So naturally it can go for necrosis. So necrosis is toxic for the child, that area. So they can produce inflammations. So they can manifest as orbital cellulitis. Can you see this? Cellulitis-like picture. Cellulitis-like picture. Can you see this? Hello.
Yes, sir.
Yes, sir.
See, beautiful cellulitis. Can you see this? Hey, Kunj is beautiful.
Yes.
Patient is suffering. Hello. Don't tell it's beautiful. Hello.
Sorry,
I
ma'am.
tell you.
Yes,
Now
sir.
that means what? Whenever you see an orbital cellulitis in a child, forget me not. Forget me not. Samjha? There are so many forget me nots in these areas.
Yes.
Actually, the forget me not word was used for different things, man. I am using this for this. In ophthalmology, they were using the retinoblastoma only in different angle, but I am using in different angle. Kunj, are you following the point?
Yes, sir.
This is what the classical things you are supposed to know. Now I given what? Patient manifesting as hypopion. Problem is there inside retinoblastoma. Patient is manifesting in cellulitis. Problem is there in retinoblastomas. That means manifesting as uveitis, manifesting as cellulitis. Underlying problem is what? Retinoblastoma, tumor. See, normally cellulitis means what? It may be from sinuses, ethmoidal sinus and all. Don't follow?
Yes.
Hypopion, usually uveitis case, you know that. But actual pathology is different. These are all called as for MCQ masquerade syndrome. Tell me, masquerade. Masking the underlying pathology. Manifesting as one, but different pathology inside. These called masquerade syndromes. Samjha Kunj?
Yes, sir.
Sure. See now, masquerade. And never forget, Pallavi, it's a future exam, MCQ, entire world exam. Need to go.
Yes.
The most common masquerade syndrome in the eye. Nothing but your B-cell lymphomas. Tell me.
Okay. B-cell lymphoma.
B-cell lymphomas will manifest as vitreous cells are there. You think it's a case of posterior uveitis, choroiditis like this. But actual problem will be different. Kunj.
Yes, sir.
Never forget B-cell lymphoma in your lifetime. Whenever you come across posterior uveitis like picture in something in even elderly persons. Samjha Kunj?
Yes, sir.
Rule out B-cell lymphomas. Chapter close. Samjha? Now, this is what classification you will be reading in your textbooks. Yeah, you are reading Corona, whichever book in the past and books. So many books are there, no? MBBS level.
Yes, sir.
This what the name is not given there. Just know it's called NAPS classifications. What that? Is only leukocoria, man. Nothing is there. Quiescent stage. Now, and he's having increased intraocular pressure. Bubustal musculus. Glaucoma stage. The tumor has come into the orbit. So, extraocular extension. I have seen now cellulitis picture. Remember? Or
Yes,
the tumor can go via the blood, via so many areas to the distant areas. Metastasis. Understand now?
Yes, sir.
Samjha?
Yes, sir.
Now I'll tell one important point. Metastasis. How the spread can take place, I'll tell you. From the eye, they can go via the optic now to the brain. This is one route. Or they can go to your choroidal vessels and all. Via vessels to distant areas. And they can involve your lymph nodes also. Preauricular, submental, submandibular. If you tell this question, no, next question, Kunj, you know that? Oh, Kunj, very good doctor, very good. Kunj, can you tell me the lymphatic drainage of the retina? I will ask you. Please remember, retina may no lymphatics. Uveal tissue, no lymphatics. Now I see preauricular lymph nodes. I see submental lymph nodes can be involved in retinoblastoma. Now the MCQ, hello. If you see the lymph nodes involvement in a case of retinoblastoma, that means your conjunctiva is invaded. Chapter close. Hello, Kunj.
Yes, sir. Yes.
If you see lymph nodes are involved in retinoblastoma, don't tell retina has got lymphatics. That means conjunctiva is invaded by the tumor, then lymphatics coming into picture. Ready to follow?
Yes, sir.
This is what the most important MCQ for the entire world. Ready to follow?
Yes, sir.
They can ask the 2-year-old child has come. The child has got a tumor inside the eye, retinoblastoma, and the child got preauricular lymph nodes and all. What is your inference? A, B, C, D. Now the question will be there, conjunctiva invaded. You take it. That's all your answer. Hello.
Yes, sir.
Samjha? Now via blood I told you to distant areas. Remember, distant areas. Now distant areas mean normally we suspect what, man? Second is in liver. We talk like this. We talk like this. Second is seen in liver. Keep on telling liver only for our world. But never forget. Kunj?
Yes, sir.
Never forget. Liver. Tell me. Stylish you tell. Tell the Kunj.
Liver.
Liver. Tell me.
Liver.
Usually. Never. Never. Tell me.
Never.
Usually we don't find secondaries in the liver. That from retinoblastoma occasions. Whereas in melanoma choroid, yes. Liver, yes. Always. It's a minor difference. Please remember this question. But then where it will go? Your answer. In retinoblastoma, your answer is to be, sir, long bones, skull bones, ribs, sternum. These are all the common sites of secondaries for retinoblastomas. Samjha?
Yes.
Liver. Neha, repeat. Liver. Tell me.
Liver.
How, what? Answer is what?
Usually never.
Yeah, finished. You get a MD OG. Oh, straight away. I'll give you. Donate to. You don't want OG, I'll give you donate to radiotherapy. Hello, don't worry. Radio diagnosis with therapy. Pallavi, you want what?
Sir, medicines.
Medicine, dental medicine. I will donate to entire college itself to you. If you tell liver, never, chapter close. And where it can go, your answer is, sir, long bones, sir, skull bones, sir, ribs, sir, sternum, sir. Finish, chapter close. Then I told you, along the optic nerve of the brain, that's all finished. How to follow?
Yes.
These words called NAPS classification. Quiescent, glaucomatous, these words given in your textbooks. But the name is not there. I'll tell you that regarding it, when you come to the treatment, why this classification is going out. Why it has been sent out. Understand now? I'll tell you. Now it's a growth pattern, I'll tell you. Imagine it's a eyeball, man. Imagine it's a retina. Imagine it's a retina. Now from retina, I told you, it's coming from where rods and cones, I told you. Now the tumor coming from rods and cones, entering straight into the vitreous. That's called going inside, endophytic.
Endophytic.
Now the tumor starting in the retina, not the point, here is vitreous. Retina starting, going backwards. Increasing in size, increasing in size, increasing in size. And is increase between the pigment epithelium and the retina, sensory retina. Now the retina is lifted. These is called exudative retinal detachments. Exudative retinal detachment. It's called exophytic growth. Exophytic means going out posteriorly. Endophyte means going inside, growing into the inside the vitreous. So that means what? Exam question is what? Patient has come, 2-year-old child is having a problem. On examination, is having a detachment. Which type of growth? Exophytic. No more questions for you. Don't tell endophytic. Understand now?
Yes.
Kunj, understood?
Yes, sir.
Retinal detachment में अगर होगा ये what? Exophytic क्या कहता है? Tell me. Hindi correct? Hello, Hindi correct? Correct?
Yes, sir.
Hindi correct? Hindi.
Yes, sir.
I was talking about recently about 40 years back only I was talking.
Yes,
Now
sir.
totally gone. See, now I told you detachment. Can you see detachment here? Retina is lifted. Can you see the blood cells and all? Underneath that a white mask, can you see? Hello? Can you see?
Right.
See now the tumor coming to the vitreous. See, a mass is inside the vitreous only.
Yes, sir.
One more thing is that the tumor is not coming forward or going up, is spreading along the retina. Can you see this? This is called plenum type or infiltrating type. That means there are 3 types of growth. One is coming into the vitreous, one is going backwards, one is along the retina. Now the beautiful question, man, Kunj.
Yes,
When
sir.
the tumor increasing in size, tell me, increasing in size, the blood supply is not sufficient. So it can undergo necrosis. Once necrosis occurred, we can have immediately followed by dystrophic calcification. Dystrophic calcifications.
Yes, sir.
You know the meaning of dystrophy? Defect in
Yes, sir.
nutrition. Dystrophy means defect in nutrition, the literal meaning. The blood supply is cut off, necrosis occurred. That's the nutrition problem. Now, because that is the calcification occurs, that's called dystrophic calcification. Exam MCQ, man. In retinoblastoma, what type of calcification? Dystrophic. Tack, 1 mark. Hello?
Yes, sir.
Exudative RD, exophytic. 1 more mark. MD, medicine for Pallavi. MD, radio for Kunj. Neha, all entire college for Neha. Suman, पता नहीं कितना सीट. Hello, who knows? Samjha, hello. Are you able to follow
Yes,
his
sir.
points?
Yes, sir.
Now, important MCQ man again. Now I told you, calcification, necrosis can occur where? When the tumor increasing in size. That means what? Exo or endophytics. Whereas in plenum type is not increasing in size. Is not increasing in size, which what? Calcification, necrosis, never. In infiltrating type. MCQ again. Kunj, understood?
Yes, sir.
Hey, they can ask you, man, what's the histological picture, a pathological picture, a microscopic picture of indifference between endophytic and infiltrating? They can ask you 4 options. Your answer is necrosis never, then calcification never infiltrating type because it is not increasing in size. Samjha?
Yes, sir.
Sure. Sure. Now we cut the eyeball. I'm going to tell you macroscopic pictures. Gross. These called cottage cheese. Tell me.
Cottage cheese.
Cottage cheese.
Hey, there are so many food items in ophthalmology, man. Hello. Kunje.
Yes, sir.
We will purposely, suppose you come to me as an examiner for MBBS exam. Come on, doctor, can you tell me some of the food items in ophthalmology? You must tell cottage cheese, sir. Swiss cheese, sir. Tell me this, sir. Burger, sir. Burger. Hello. Little space of began the lens. You got space called burger. Burger space.
Burger
A
space.
burger. You know, Herald Ridley. First of all, put IOL. You know that? IOL. Idli. Tell me, Idli. Hello.
Okay.
Ridley. You remove R, man. Idli is coming.
Illy.
Samjha? So, food items in ophthalmology. Hey, tomato splash appearance. Here are the occlusions. Tomato ketchup. You know that?
Yes, sir.
Pizza pie appearance. Tomato ketchup appearance. Same cytomegalovirus retinitis. That's why I'm telling you, Kunj. Hereafter, whenever you take pizza, think you are eating CME.
Sir, we cannot eat then.
And then that's the reason. Don't eat pizza, useless. Hey, if for that you can read something, eat some good salads. You purchase and eat salads, man. Hello. Why pizza pie waste money and creating confusion for you? Kunj, correct, no?
Yes, sir. Absolutely.
You tell Ramya, madam. Ramya ji,
Sir, I'm eating salads only, sir.
pizza, sir. You're eating pizza, va?
No, sir. Where? No pizza, nothing.
No, pizza pie you are taking. Pizza. Ramya, never
Yes,
take.
sir. Sir, not eating, sir, pizza. Anyway, it's only salads here.
That's why. Better you take some vegetables or fruits. That's enough
Yes,
to
sir.
survive in the world. Samjha, Ramya?
Yes, sir. Thank you.
It's called cottage cheese. You know, Kunjwala, Swiss
Yes,
cheese
sir.
pattern, they will ask you. Swiss cheese pattern. Just remember one point. For example, MCQ. Band-shaped keratopathy is a complication of uveitis. Corneal, you can have calcifications. That can show a Swiss cheese pattern. And microscopic appearance, tumor. Adenoid cystic carcinoma lacrimal gland will have Swiss cheese pattern. Adenoid cystic carcinoma, you might have heard, hello, glands.
Yes, sir.
They can have a Swiss cheese pattern because last year we only studied pathology. Samjha? Of course, you would have forgotten. Doesn't matter. Okay, nobody can remember everything. So unless you have to go for house urgency, again read. Till you die, you have to read. Till the age of 80, 90, you have to read. Keep on reading. Otherwise, you will be deleted. Samjha?
Yes, sir.
Kunj?
Yes, sir.
Now I told you necrosis, remember? Why necrosis I told you, remember? It's a dystrophic calcification, remember I told you?
Yes, sir.
See calcification, can you see a white area? Can you see this area, white area?
Yes,
Within
yes.
the tumor, you can see calcified areas. I'll tell you. Very rarely, I told now, you see, why calcification necrosis? Because of blood supply is cut off. It's not sufficient. If the blood supply is not sufficient, so much extent, the tumor may die also. Necrosed, total tumor is necrosed. And that is what you want. Exam question, spontaneous regression very rarely can occur in retinoblastoma. Spontaneous regression of the tumor can occur in retinoblastoma patient because the tumor undergoing necrosis totally. That is what we aim, man. We give treatment, we are necrosing only, producing necrosis for the tumor only, killing it. Pallavi, exam question for you. MCQ for international exams. Can I get spontaneous regression, doctor? Yeah, so no. Yeah. Tell me.
Yes,
Yeah,
sir,
tell
yes.
me.
Yeah.
Yeah, so.
Yeah, it can occur.
Yeah. Now it's Rajinikanth style. It's called Rajinikanth style. You know Rajinikanth, no? Hello.
Yes, sir.
Because he's from Karnataka only.
Yes, sir.
Kunje.
Yes, sir.
Yeah. Tell me. Yeah.
Yeah.
That's all. You're finished. Now I'm going to see the microscopic structure. What's happening? The typical suppose I say a retinoblastoma cell, man. I can't say it's rods and cones, man. It's a primitive rods and cones. Now I tell you, how is it look? It's a small cell. Tell me. Small cell. Large nucleus inside. That means nucleus large means cytoplasm will be scanty. These three sentences you are supposed to know. A small cell, large nucleus, scanty cytoplasm, the classical picture of retinoblastoma cells. That means when you see this cell, when you see this tumor cell, you cannot tell it's a tumor rods and cones. If allowed, it would have gone to rods and cones. I told you, it's a primitive rods and cones. By seeing the cell, you can't say. Or you follow up. Yes. Now I tell you. They are supposed to be arise from primitive rods and cones. Remember I told you. Now we see the problem. Microscopic. Now I'll tell you here. A lumen is there. Tell me. Lumen. Surrounded by tumor cells. That means it is called true rosette. A lumen is there, surrounded by cells, tumor cells called true rosette. Is a true. Or imagine now, a blood vessel is there, blood vessel, surrounded by tumor cells, a pseudo rosette. Understood? A lumen is there, true. Blood vessel is there, pseudo. That means that is surrounded by tumor cells. Understand now?
Yes.
The lumen is empty. Nothing is there inside. Flexure intestinal. Yes. Lumen has got some materials like this. That means lumen is not seen. Homer right. See now here. See some semi-cellular material. Can you see here in this area?
Yes.
This Homer right. I want to see now here. Can you see in this area? See the lumen. Beautiful lumen. Can you see this? Hello.
Yes, sir.
Conch.
Yes, sir.
Now beautiful lumen. Can you see this area? Can you see here?
Yes, sir.
This is called flexure intestinal. This fellow is called as Homer, right? Because lumen has got some can you see them? Something is bluish color. These are all actually called as neurophilic materials, called neurophils. No, neurophils. Samjha?
Yes,
now, what happens now? This flexure intestinal, Homer right, then pseudo rosettes, all may be seen in your retinoblastomas. But the most common is flexure intestinal. But follow? Anything can be seen. But the most common is what? Flexure. Understand now? That lumen is empty. Sometimes you will have lumen all man. Oh, lumen is there, man. Lumen is there. But the lumen is there. What happens now? They are having a cells, a longer cells. Not small cells. Longer. That means what? They are all looking like rods and cones. That is called as fluoride. Tell me fluorides.
Fluorides.
See now, can you see a long cell? Can you see this area? But lumen is here. Please remember, lumen is here. But you see, cells are not round. These also arrangement fluorides. That means what? In retinoblastoma, we can have true pseudo fluoride. The most common is true rosette flexure intestinal. Finished. Samjha? Next, international exam questions, man. Hey, Kunch. International exam question, what? Doctor, you have seen now rosettes in the retinoblastomas. Can you tell me one more tumor inside the eye which will also show rosettes? Tumor. That means your answer should be, you know what's happening in the retina and all? You know that? Hello, imagine, can you see the picture now? Can you see the picture here?
Yes.
I'm drawing. Because it's also red in color. That's why I think you may not see properly. I will put white. See now, we have got, imagine man, hello, this area, eyeball. Your bloody flow, bloody means what? Retina. Can you see me? Retina coming. And you know, retina, there are two layers, you know, the outer layer and pigmental epithelium and sensory retina. Both are from inner layer and outer layer cup, you know that.
Yes, sir.
When you come forward in the retina, just imagine now, you are walking in the surface of the retina, man. You are walking. Imagine you are walking on the surface of the retina. Now come forward, you go to ciliary body. Now from there you again ascend, you go to iris. That means iris backside, pigment epithelium. Ciliary body epithelium, retina, these are all continuous.
Yes.
Developmentally, that means what? Ciliary body epithelium, you got two layers. Similar to your retina. Sensory retina, pigment epithelium. That ciliary body also got two. Similarly, iris also got two epithelium layers posteriorly. But never forget, sensory retina is continuously inner layer. You know this inner layer, ciliary body. Pigment epithelium is going as outer layer of the ciliary body, epithelium. Inner body, inner layer of your ciliary body is non-pigmented. Outer layer, as in retina, is a pigmented area. But never forget MCQ for the entire world. You got iris. Iris were two layers of epithelium. I told you, two layers similar to that. But both layers are pigmented. Never forget that. Iris में both layers are pigmented cells. You cannot change it. Are you follow?
Yes, sir.
Now the question is what? I asked you one question. What? Rosettes are there. Which other area can have similar rosettes? I told you developmentally or ciliary body epithelium is same thing. Retina.
Yes, sir.
Same retinal development only.
Yes,
That
sir.
means what? A tumor coming from your ciliary body epithelium may have rosettes. Understand now?
Yes, sir.
That is called as MCQ for entire world. Hello? Decatayoma. Tell me decatayoma. Otherwise called medulloepithelium of the ciliary body epithelium. They will have rosettes also, like your flexner interciner. They can appear. Understood?
Yes, sir.
समझ गया?
Sir.
Now we see one more area. Retina what a maldevelopment displays the conditions. That is called Nuri disease. Of course, when you ask no DD, different like for retinoblastoma, you can tell Nuris also. They will also have white people. So never forget rosettes, not only in retina, inside the eye. I can have in ciliary body tumors called dictoyomas, epitheliomas, or even in retinal dysplastic conditions like Nuris. This is what MCQ for your entire world exams. Conch?
Yes, sir.
Now next question. I told you now there are three areas I can tell you inside eye. Remember? Now homarate rosettes are seen where? I told you lumen has got something is there. That's called homarate. I told you homarate. Yes, inside you got neurophilic, but it's a true rosette only. True rosette. This can be seen in retinoblastoma. I told you. This can be seen in retinoblastomas. But outside you come MCQ again. Neuroblastoma, adrenal will have homarate. And cerebral medulloblastoma will have homarate. These are all I told you. I am not allowed. I told you. Yeah, I'm talking about even for your future also. NEET exam also. These are the questions they can ask you, man. Exam. Understand now? Of course. समझ गया?
Yes, sir.
Now spread I told you through the optic now. Via the blood I told you. Retina has got no lymphatics. Remember I told you. But they can have involvement of nodes. Remember I told the reason conjunctiva is invaded. I told you conjunctiva is invaded.
Yes, sir.
Remember?
Yes, sir.
Now the most important MCQ for everywhere. Hello. Kunch.
Yes, sir. Yes.
Now you see, doctor, I am taking a specimen, microscopic specimen from your lymph nodes or some bone. I told you bone deposits. Now I take a picture or something microscopic structure from your eye, primary site. There are two slides given to you. Under microscope you are seeing. Under microscope you are seeing. Can you find out from the slide this is from primary site or this is from secondary sites? Is it possible? Metastatic site, is it possible or not? This is what MCQ for you. Your answer should be Kunch. Your answer should be, sir, in metastatic area, we will have abundant blood supply. Necrosis, calcification will never occur. In primary sites, exophagic, endophagic, you will have necrosis definitely. Don't follow?
Yes, sir.
Because of abundant blood supply in the metastatic site, you will not expect necrosis and calcification to occur. This is what classical MCQ for whichever exam you want. Hello, Kunch.
Yes, sir. Got it.
समझ गया?
समझ गया, sir.
भूल जाएगा?
नहीं, sir.
कभी भूलना नहीं.
Yes, sir.
कम से कम तो याद रखो.
हाँ, sir.
Liver, I told you, very rare, never. Remember, I told you. I told you, compared to melanoma core, I told you, liver always. I told you, remember. Now, different diagnosis. When you have a white people, see, suppose the question is asked, man, leukocoria, white people, you must try retinoblastoma is one of the causes for leukocoria. Understand now?
Yes, sir.
Suppose you're asked pseudoglioma, because retinoblastoma was called as those days a glioma. Anything mimicking retinoblastoma, that means what? You have to write mention about retinoblastoma. You have to write something else, others in the leukocoria area. Leukocoria means you have to write retinoblastoma as a DD. Whereas pseudoglioma means you have to mention pseudoglioma. Retinoblastoma was called as glioma, a problem mimicking retinoblastoma, maybe other cancer. Same thing only you have to write it. See the minor difference.
Yes, sir.
Pallavi, understood?
Yes, sir. Yes, sir.
Now we see, these are all some of the things you are supposed to, it's given in your textbooks also. You have got Coats disease, primary vitreous hyperplastic, then toxocariasis. Remember, I told you dictyoma, remember?
Yes, sir.
These are some of the DDs. I'll tell you, Coats is nothing but it's a unilateral case. It's a unilateral condition, one eye condition normally. Usually in children, boys, before first, that is end of first decade. See, retinoblastoma can occur 2-3 years, I told you. 2 or 3 years age. Whereas this can occur about 7-8 years like this. Retinoblastoma and bilateral also I told you. But this fellow is what? Usually unilateral. Now what MCQ in this course is they will ask you for future. See, they will have abnormal vessels in the telangiectatic vessels in the retina. Dilatations. That is called as Leber microaneurysms. Tell me, Leber microaneurysms. MCQ. MCQ is what? Leber microaneurysms are seen where? Coats. Pallavi, understood?
Yes, sir. Yes, sir.
Leber microaneurysm can be seen where?
In Coats disease.
Very good. समझा?
Yes,
भूल
sir.
जाएगा?
नहीं, sir.
कभी, अभी, हमेशा के लिए याद रखना.
Yes, sir.
Hello? Hello? நான் அப்புறம் பண்றேன், கொஞ்சம் கிளாஸ்ல இருக்கேன், கொஞ்ச நேரம் கழிச்சு பண்றேன். அதான் ஜக்கி ஒரு 1/2 மணி நேரம் கழிச்சு பண்றேன், நானே பண்றேன். அதான் நான் பண்றேன், கிளாஸ்ல இருக்கேன். அப்பா ஹலோ ஜகனி, ஹாப்பி நியூ இயர், ஹாப்பி நியூ இயர். Hey, my classmate recently was my classmate about 40 years back. Understand now? My MBBS classmate recently 1974, 75 and all. Understand now? My classmate.
Yes.
He called me now Happy New Year. Samjha? That's why poor chap. Understand now?
Yes.
Okay, that means what? Coats got at least 1 point, man. Unilateral boys, the males, first end of first decade ka end, Leber microaneurysm. These 3 or 4 points you must remember, Nick, for exam, for your entire life till you get your PG, finish your PGs. Similarly, hyperplastic primary vitreous. When I take class in the future, I can tell you what is vitreous and all. You know what's happening? Vitreous have got 3 developments: primary vitreous, secondary vitreous, tertiary vitreous, like this. Primary vitreous, it has to produce secondary vitreous. By chance, it's not doing that. It's remaining. It's a persistent. That means what? The eyeball, only when secondary vitreous is produced, it has to increase in size. When the secondary is not produced, I will be very small. So microphthalmic eye, tell me microphthalmic eye. Small eye is a classical finding. In persistent hyperplastic primary, eyeball will be small because of microphthalma, small eye because of secondary vitreous not developed. This is a classical feature of trisomy 13 MCQ. Patavu syndrome. Patavu, Pallavi. Patavu.
Yes, sir. Patav syndrome.
Patav, tell me.
Patav.
Patav. Edwards.
Edwards.
Downs.
Downs.
Tell me what is trisomy 22?
Don't know, sir.
That is what MCQ. Tell me. That is what MCQ. Of course, unrelated with this area, but because if Patav came, I'm remembering something. I'll tell you something extra. Trisomy 22 means patient can have coloboma iris.
Okay, sir.
Along with anus and rectum atresia.
Okay,
Coloboma means what? I said slit like man. Inferior slit like, slit like.
yes, sir.
That is why it's called cat eye syndrome.
Okay, sir.
Kunj, cat ka eye, cat,
Yes.
Cat ka eye dekho, you see the vertical slit. This fellow has got coloboma. It's looking like a cat. That's called cat eye syndrome. Trisomy 22. This is what? Conch for future. Tell me.
Yes,
For
sir.
future exams, man.
Yes.
Then Toxocara canis. Dog problems. I already told you dictyoma, ciliary tumors. Remember? Can you see now coats? See now small dilated vessels. Can you see in this area?
Yes, sir.
These are all what supposed to be called as labors.
Labors microaneurysm.
Next is now personal plastic pyramid. See this eyeball. You compare to the other eyeball. See the large small size. Can you see this? Hello. Now
Yes.
this is Toxocara. Optic disc. Something a granuloma is here like this. So they are attached. They can even have calcifications, man. The Toxocara coats and all. They can have calcification inside. Sometimes
Okay,
I
sir.
told you middle of it's called retinocytoma. Of course, doesn't matter. Remember trisomy, patau. Never forget microphthalmas. I told you coloboma. Remember unilateral.
Yes,
One
sir.
more point. The ciliary body process. Ciliary process. They're all very long in here. That's all. Because microphthalmic eye. This what persistent plastic primary which is got features. Next is now. Other EDs. Congenital cataract. Never forget that. Hey, Kunj.
Yes, sir.
Suppose you're asked DD, leukocoria, retinoblastoma, next you write congenital cataract, nothing wrong. Afterwards you can write PHP course and all, doesn't matter. The most common only you're supposed to know. See now, retinopathy premature from history you can find out. Then, of course, they may not ask you. It's called familial extended retinopathy, autosomal dominant problem. Nuri, I told you, remember? Nuri, rosettes.
Yes, sir.
Incontinent pigmenti, they will have skin disorders along with detachment of retina. That's why it's white. Leukocoria, incontinent pigmenti. Hey, Kunj, they will have skin lesions, along with the problems in the eye. Leukocoria.
Okay, sir.
Can I ask one question, Kunj?
Yes, sir.
Hey, you are having so many skin lesions, Hey, I'm seeing your eye. You are having leukocoria. You are a case of incontinent pigmenti. I'm telling you now. Can you agree or not? I am telling you now, you are having skin lesions along with the leukocoria. I am making a diagnosis of incontinent pigmenti for you.
Yes, sir.
Can I make or not?
Think, Kunj.
Kunj, come on, Kunj. Kunj, I'll tell you the answer. Don't worry. I will ask one question. Don't be angry with me. Don't be angry with me. Kunj, you are male or female? You are male or female?
Male, sir.
Male. These are all X-linked dominant problems. X-linked dominant lesions, adult male, very, 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 very remote. That means if suppose it occurred in you, you would not have seen in your first birthday itself.
Oh, yes.
Hello, the very fact now you are 20 and all, you are sitting here and listening to my lecture. That means it cannot be incontinent pigment. Like that you can tell.
Yes.
That means X-linked dominant problem in male, usually, I'm telling you, exception can occur. Usually they will die before first year of age. Hey, XY chromosome,
Yes,
X is
sir.
dominant, wife out.
Yes, sir.
If a XX female, X is dominant, so what? This exercise. So X-linked dominant problems like incontinent pigment can, if at all you can see, it's females, adult females. You know why I'm telling you now? Why I'm telling you now this question? Same question comes in exam for your future. Sir, a 25-year-old male patient has come. He's having skin lesions and he's having leukocoria also. All are correct except something may be there. That incontinent pigment be there. That is what wrong answer. Understand now?
Yes, sir.
Incontinent pigment can never occur in 25-year-old male. Understand now?
Yes, sir.
This is the way I have to approach. Conch dabala. Samjha?
Yes, sir.
See now, here. These are all, of course, retinopathy premature. These are all, when you read, you can understand. I'll tell you. See now, you can have coloboma here. Samjha? See now, all these familiar, all these things, of course, they may not show you. But they will show congenital cataract. Can you see cataract here?
Yes, sir.
White.
This can be shown in the exam also. Or they can show you slides also, nothing wrong. But these things are all very rare to allow because these are all PG level. But for you, NEET exam, they will ask you, that's all. investigations. Suppose what can investigation? You tap the aqueous humor. You see lactic LDH, dehydrogenase. Normally, you see the value is all the MCQs for you. 1186 international units per liter. This is the amount of LDH in the aqueous. You tap the aqueous, man. This international LDH level. Normal. By chance, this fellow is increased. Think some problem is there inside. What problem may be retinoblastoma? Understand now. So LDH level in the aqueous tumor, if it is increased, think about maybe a case of retinoblastomas. Are you follow?
Yes.
sir.
Next, most important ultrasonogram. You know B scan, A scan, you know that. Hello.
Yes,
You
sir.
heard about it
Yes,
at least.
Yes,
Or
sir. Yes,
they are
sir.
teaching you retinoblast, ultrasonogram. These are all waves, man, sound waves. Suppose I'm shouting it. The sound is traveling towards you on the laptop. Now reflecting from there, coming back to me. How these coming up? I record it. That is the way I'm going. That's what B scan, understand? A scan. How the sound is going to be reflected. Suppose a solid object, they can get easily reflected. Something very easily allow is it can easily travel. Suppose the tumor is there, nothing is inside. They can easily travel from one end to another end without any obstructions. If something is there inside, they can allow reflect the sound, which can be recorded in the A scan, B scan. What is A scan, man? You can see the amplitude going up and all. B scan is two-dimensional picture, that's all. I'll tell you very simple, you can easily understand, I tell you. See now, can you see this picture? Can you see this picture? Hello?
Yes.
Quench.
Yes, sir.
Quench.
Yes, sir. Yes, sir.
You have seen the picture. You see now, this is called, hello, why the color is not changing? I tell you. See now, can you see a tumor mass?
Yes.
That means what? You got hyperechoic. That's where they are bright.
Absolutely.
They are all bright in color. But now you see a line going inside. This is called vector. Vector. It's called vector. Vector. Corresponding in the vector area, how the A scan is a one-dimensional time amplitudes. How the amplitude going up or coming down, like that. Getting reflected or no, not. When it's reflected, you see corresponding surface of tumor, you see a high wave going up. Can you see this? But inside the tumor, what will be there in retinoblastoma? I will tell you, they will have necrosis. They can have calcifications. Wherever the necrosis, that sound can easily move without any hindrance. Wherever calcification is there, they go and strike and come back again. That means it is not uniformly allowed. Some area calcification, some area necrosis. That means what you see now here. The wave goes up and coming down, coming down. Can you see going up and coming down, going up? And can you see this?
Yes, sir.
It's not
Yes,
uniformly going up like this. Some area necrosis is coming down and going up, going up. See the coming to the orbit like this orbit area. That means this is the area of the tumor mass. That means what? It is not evenly getting reflected. Some area reflected very high, some area going down. The amplitude is coming down. This is called the baseline. Baseline. The amplitude coming down means what? The amplitude is less. That means what? Inside the tumor, we have got what is called necrosis. The sound wave can easily move. Wherever calcification, the sound can get reflected, which can be seen as amplitudes. That means what? Irregular reflections. Some area reflection, some area no reflection. This is called VY pattern. Tell me.
VY pattern.
VY pattern in A scan is a feature of retinoblastoma. MCQ for entire bolt. Neha, understood?
Yes, sir.
Samjha?
Yes, sir. VY pattern.
VY, stylish. VY, tell me. VY, tell me.
VY.
Stylish.
VY pattern.
Yeah. Tell me. VY. Now I will compare one thing so that they can. Okay, imagine a melanoma choroid, man. Imagine melanoma choroid. Melanoma choroid में क्या होता है? First surface reflects. Inside the tumor, very few small reflections because only vessels. There is no solid structure. Please remember. So mild reflection, that's all. But posterior wall again getting reflected. That means what? The wave will go like this. Please remember. First wave go like this. Then coming downwards, mild reflections. Can you see this? Or maybe slightly moderate. That's all. To follow. Then again, posterior wall going up. The amplitude will go up. So melanoma choroid is what now? Internally, as if nothing is there. Acoustic sound, acoustically hollow structure. So melanoma choroid is acoustically hollow. Samjha?
Sir.
Now we see, I'll do one more point. I'll say for MCQ. See, now I draw the first wave, I draw a horizontal line. Now the remaining waves, you connect all the lines. You connect the waves, remaining thing. Remaining height, no, you connect one more line. That means the horizontal, first wave horizontal come, and the remaining line, you can have an angle is created. This angle is called kappa angle, kappa.
Okay.
See, I'll tell you in this case, you see now. Here the wave is going up and coming like this, going up like this. Can you see this? Retinoblastomas. See the first wave angle going like this. The remaining wave, see the angle like this. The kappa is very small. Angle kappa is very small in retinoblastomas. Angle kappa more in melanoma choroid. The comparisons.
Yes.
Kunj understood?
Yes, sir.
Yes.
Pallaviji.
Yes, sir. Yes, sir. Understood, sir.
Very good. Tell me. Now, next, I told him ultrasound. CT also has to be done. CT. CT can be used to what? To see calcifications and all. Know that.
Yes, sir.
See, inside eye can have calcification. Or suppose the brain I can have calcifications. The pineal body. Everything can see. But for a soft tissue, optic nerve is involved. Is progressing by optic nerve. MRI is better.
MRI.
Because inside eye told you calcification can take place. That's a better seen with our CT scan.
CT scan.
But the problem is what now? CT scan is also X-ray like thing, man. Hello. Radiations. That means what? They can get second malignancy because if a problem is there, hereditary patterns. That's the drawback of CT scan. Understand now?
Yes.
See now here. Can you see now? CT scan is called axial view. As if you see from top, man. Hello. You see from top. See the orbit is there? Orbit. See the brain and all. Can you see this?
Yes, sir.
This is called axial view. Axial view. It's called axial view. See now we got one area hyper lesion is there. See here also right also you got so many lesions. Now your answer should be sir. Hyper dense lesion. Tell me. Don't tell echo. Hyper dense lesions, which can be seen inside the eye. That's the way you have to answer in the exams. In CT you must use the word dense. In ultrasonogram, you use the word echo. It's a sound. Whereas in MRI, you must use the word intense.
Intense.
I'll tell you MRI. MRI, you know what? I told you soft tissues. See now, you can see now eyeball. See a mass is here and you see the optic nerve is enlarged. That means what? The tumor has gone via the optic nerve. Can you see this? Will you follow?
Yes, sir.
That means what? MRI can be used to find out, see now, optic nerve evaluation, outside eyeball problem. Is there any primitive, hello, trilateral, I told you pineal body. Understand now? Now, MCQ for entire world. Doctor, you have diagnosed of retinoblastomas. Okay, you have confirmed everything over. Now you have to give treatment. You have to give treatment. They will ask you what? Which is the most important investigation to be done before initiating any treatment? Kunch is what MCQ. Which is the most important investigation to be done before initiating any treatment for retinoblastoma? Your answer is, sir, I would like to take MRI brain.
Yes, sir.
Or CT scan brain. C for pineal body area. If pineal body is okay, you give treatment to the eye. If a pineal body problem is there, then I have to think about medication, pharmacological treatment only. Chemotherapy only, the treatment.
Okay.
Yes.
Samjha?
Yes, sir.
The most important investigation to be carried out before initiating any treatment for retinoblastoma is MRI or CT scan brain. Rule out pineal body and the chapter is closed. Samjha?
Yes, sir.
Are you able to follow me? Hello?
Yes, sir.
Yes, sir.
Sure. I told you MRI is currently preferable. I told you because of soft tissues. And moreover, what CT what can produce what problem? I told you secondary tumors and all. Mutation can take place.
Radiation in.
Very good. Now, of course, these are all Other areas, you can do bone marrow. I told you, hello, you can put the bone, I told you. Then I can go to lumbar puncture. These are all normally we don't do. Okay?
Yes.
Bone marrow, we don't. Now I told, remember, naps I told, remember?
Yes, sir.
Yes, sir.
First quiescent, extraocular extension. Then, hello, sorry, second is
Glaucomatous.
glaucomatous,
Glaucomatous.
extraocular extension, metastasis.
Metastasis.
This called first, second, 3, 4 stage. Now, naps that classification, hello, based on that, they were giving what treatment? 1, remove the eyeball. 2, remove the eyeball because everything confined within the eyeball. What for you remove the eyeball? You are removing the tumor as well as the eyeball. That means what? You are saving the life of the patient. Life of the patient you are saving. Understand now?
Yes, sir.
Samjha?
Yes,
This is
sir.
what based on naps. Then what? Third is coming to the orbit. You remove the entire orbit. That's called exenteration. Exenteration. That means you remove the entire orbital contents along with the bone surface. You know, we've got periosteum. Periosteal covering also is removed. Exam question for you. They will ask you, what do you mean by exenteration? Your answer is removing the contents of the eyeball, contents of the orbit along with the periosteum. That's all. If it is metastasis, chemotherapy. That's all. Samjha?
Yes, sir.
Next pair. You see this fellow, Reese. You see the one fellow came, Reese. See what's happening in naps that said that calcification based on that we are doing treatment. Very small tumor inside there, but they were removing. Even 2 millimeter height, 3 millimeter, they were removing the eyeball because they want to save the life of the patient. And this fellow told, why do you want to remove the eyeball? If you have given, if you're able to give, I'll follow. Radiotherapy, you can cure the patient. If you're able to cure the patient, he can use the eye for visual purpose.
Yes.
And he can save the life of the patient also. See, now 2 things are achieved. That's what Reese told. No need to remove the eyeball always. You can have some idea, some tumors. He gave so many classifications. Based on size of tumor, location of tumor, we can give radiotherapy. Otherwise, if I have to give enucleation, like that he was telling. Samjha? Will you follow?
Yes, sir.
The problem is what? He told what? Radiotherapy, remember? But I told you what? If it's a hereditary pattern, radiotherapy can induce mutation in the bones.
Yes,
That
sir.
means you can't give radiotherapy for everyone. Samjha?
Yes, sir.
This is how the development of tumor, this thing, treatment for the patients. See, internationally, what did I tell you? They told very small tumor, you can try laser. Samjha? I'll give you, hello, here. This is what NAPS area. Hello. I told you,
Yes,
remember
sir.
NAPS? Quiescent, enucleation, glaucomatous enucleation, extraocular exenteration, metastasis chemotherapy. Remember I told you?
Yes, sir.
Then I told Reese what he told about external beam therapy, radiotherapy. I told you. I told you the mission, linear accelerator, never forgets an MCQ for you. Next problem is now. Now I told you hereditary patterns. Now that present day, what's happening now? You have 2 millimeter size. Imagine it's a tumor mass, man. Hello, it's a tumor mass. 2 millimeter height of the tumor and all. See now, I can apply laser around the tumor. Or I can apply intense cold, cryopexy around the tumor. That means the tumor has got blood supply. You cut off the blood supply. Tumor undergoes necrosis. Samjha?
Yes, sir.
If the tumor mass is very small, apply laser cryo around the tumor. Finished. Or I can give into the tumor, infrared radiations. We have got some lasers. Some lasers which can produce infrared rays. That means they can produce temperature increase. Now the infrared entering into your tumor, increasing temperature to 60 degrees, the tumor cells die. That is called transpupillary thermotherapy. You are inducing temperature inside the tumor. These are all options available for us when the tumor is very small. Laser, cryo, transpupillary thermotherapy. Understand now? 3 things.
Yes.
Samjha? Suppose the tumor is slightly large, man. Hey, imagine his eyeball. Now, here, suppose the tumor is very small. Like I told you, I can apply laser. Suppose the tumor is slightly larger, or 8 millimeter. Imagine now 8 millimeter size. I can't apply such a big laser on something difficult. What I will do, I will apply, brachytherapy. Tell me.
Brachytherapy.
What is brachytherapy? Radioactive materials suture over the sclera. And they can emit radiation, kill the tumor. Have to follow.
Yes.
Yes, sir.
Brachytherapy can be tried if the tumor height or something like that, 8 millimeter. And you do this. Suppose, imagine one more case. A tumor has got more than 15 millimeter size, man. Hello. 15 millimeter. For example, I'm telling you, 15 millimeter. Now I can't apply large brachy. Hello. Brachy I cannot apply. In that case, I have to go for external radiations from outside. External beam radiation, I told you, radiotherapy. But the problem is what now again? Hereditary pattern, second malignancy. In that case, what to do? Your answer is, sir, give chemo first. You tell me, chemo. Now the 15 coming to 7. That means chemo reduction taking place. Now you apply brachy over it. Brachy. If suppose radiotherapy is contraindicated, I can give chemo reduction followed by brachytherapy. Also, you must tell this. Follow?
Yes, sir.
Then by chance, more than half the retina, everywhere I can't do anything. More than half the retina is involved. VT is also involved. And the vision is very poor. Remove the eyeball. That's the last stage. Samjha? 2 millimeter laser cryotransmipillary. 8 millimeter brachy. 15 millimeter external radiation. If contraindicated, chemo reduction followed by brachy. More than that, half the retina is involved. VT is also involved. Visual progression is very poor. You remove the eyeball. Hey, for your son, if you know this more than enough, understand now? Kunch.
Yes, sir.
Samajh gaya?
Ah, sir.
I told you, around 15 millimeter external radiation therapy. If Kaneka, I told you what? Chemo, brachy. I told you, remember? After retina is involved, I told you what? Enucleations?
Enucleation.
If orbit is involved, I told you what? Orbit is involved. Previously what? Excenteration, remember? Orbit.
Yeah.
Now we don't do that. You just chemo and radio. Finished. Now you have to give chemo and radio.
Yes.
If the orbit is involved, the same treatment, never forget this exam question. The same modality of treatment holds good even for your rhabdomyosarcoma in the orbit.
Yes.
Chemo and radio. Suppose they give chemo radio, man, the tumor coming down. Again it's coming back again. You are giving again the external radio, this you are giving. Again coming up. That means recurrent tumors. Now your answer is accentration. Follow? The first method of treatment is for orbital problems. Your answer is chemo radio. If recurrent, in that case you go, remove the entire orbit. Samjha?
Awesome.
Metastasis chemotherapy, that's all. I'll tell you some of the standard, at least know the names of the drugs. Vincristine, etoposide, cisplatin, these 3 drugs. If you want, you can tell the names. There is a dose. Otherwise, it doesn't matter. Because everything will be given as what? Oncology will give us something recommendation. We are going to carry. That's all. At least you know the name of the drugs. Vincristine, etoposide, cisplatin. These 3 drugs are given. See now these 3 days today. From today onward, 3 days maximum. After 21 days, one more 3 days. After 21 days, 3 days. That means what? Each cycle lasts about 3 days. Every 21 days, one cycle. That means you can give a cycle of 6 to 12 cycles. That's all. Chemotherapy is given for metastasis. I told you. That is what? 3 days in a month. Something 21 days. Each 21 days you have to go. That's called one cycle. 3 days is a cycle. 21 days one you have to repeat. The drugs are these 3 drugs. Vincristine, etoposide, cisplatins. Samjha?
Awesome.
There are some different alpha. These are all for PGs. Understand now? These are all for PGs. Understand now? That's why I don't want to mention. Other drugs we got. Other drugs. But vitreous inside some problem is there. Vitreous tumor cells are there. Now I can give intravitreal melphalan. Now I want to deliver the drug directly to the tumor mass. I can introduce in the carotid artery or into the ophthalmic artery. Introduce intraarterial melphalons. They can go and directly supply your blood supply to the tumor mass. Finish. Tumor is getting out. Or suppose vitreous problem is there. And you know, we have got conjunctiva is there. Under the conjunctiva, no Tenon's capsule is there. You know that order. Tenon's capsule. Under Tenon's, you inject cisplatin. Cisplatin can be injected under Tenon's capsule. What for? To treat the vitreous problems. Understand now? These are all for the vitreous problems. Please remember. Other drugs what for? Intravitreal melphalan. Intraarterial melphalan for the tumor mass. Subterenal injection for cisplatin for vitreous problems. Will follow?
Yes.
Samjha? Then one more drug. Just know the topotecan. Topotecan is what? Topoisomerase enzyme inhibitor. You know what's the meaning now? This enzyme is a must for cell division. If you give a topotecan is inhibiting the enzyme, naturally cells cannot divide. The problem is solved. A tumor is what, man? Rapidly dividing cells. They require this enzyme. You inhibit the enzyme. Tumor cannot divide. That's called topotecan. It can be given oral. It can be given IV also. These are all the treatment you are supposed to know. Now you see now this is they will ask you an exam. This is called enucleated spoon. Can you see this spoon? Hello?
Yes, sir.
Can you see now gap? Can you see a gap here?
Yes, sir.
Hello?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
This is to hold the optic nerve. This is called optic nerve guide. Suppose the example, if you show this slide, the instrument, you must tell it's an optic nerve guide or enucleation spoon. Samjha? Hello? This is what the most important entire world exam. Kunch?
Yes, sir.
Now they go. This is what optic nerve, man. Can you see the optic nerve? Can you see the optic nerve? Hello?
Yes, sir.
Diagrammatic representation. Understand now?
Yes, sir.
Hey, this pen is not working properly. Yes, I'll bring laser marks. Lasers. See the optic nerve. Can you see optic nerve here?
Yes, sir.
This area is eyeball, man. Hello. This is called eyeball.
Yes, sir.
Yes,
This is called, you know one thing? It's called distal portion of optic nerve. Never forget that.
Mm.
Just because coming from eyeball, don't say proximal. It is the distal portion of optic nerve. Towards the brain only, it's proximal.
Proximal.
Samjha? It's
Yes.
a classical exam question. I have seen many students are fumbling there. That MBBS students will fumble. See now here, what's happening here? This white color, no, can you see white light, white color?
Yes, sir.
Yes.
Can you see the hello picture?
Yes, sir.
Yes, sir.
This is called central little artery.
Mm.
This black is called central little vein.
Mm.
That means they're going to supply your retina and training, that's all. But the CRA is branch about ophthalmic artery.
Mm.
Therefore, CRA has to come to where? Retina, to supply retina. How can it come to retina? It has to enter the optic nerve, then only they can come inside via the optic disc. This fellow, CRA, enters your optic nerve about 10 millimeter behind the eyeball. Now we see when it is coming inside, you know, optic nerve is nothing but a brain. That means you got dura matter, pia matter, arachnoid, everything is there. That means it has to pierce and come inside. Understand now this point?
Yes, sir.
Now we see, when I do enucleation, I have to cut the optic nerve and remove. That means optic nerve guide I have to hold, then cut the scissor and remove the eyeball. That's what you are going to do.
Yes, sir.
But 10th millimeter what? Your CR is entering. But follow.
Mm.
I will follow.
Yes, sir.
I never forget CRA enters 10 to 12 millimeter behind the eyeball MCQ. CRA is a branch of ophthalmic artery MCQ, which is supplying your retina MCQ. Samjha? Now it enters about 10 millimeter. I told you approximately 10 to 12. Now when I cut the optic nerve, exam question, man, how much of length of the optic nerve to be cut? They will ask in exams. When you do enucleation for the retinoblastomas, your answer, sir, it is as long as possible. Kunch. As long as possible. At least must be more than 12 millimeters.
Okay, sir.
Samjha?
Yes, sir.
Now, why doctor? They will ask you, why doctor you want a more long optic nerve? Your answer is, sir, after cutting the optic nerve, I cut and I will subject for histopathology. Cut and I will subject for histopathology examination. If the cut and shows retinoblastoma cells, remember now, the retinoblastoma can spread along the optic nerve, I told you. It can go. Now 10th millimeter, this fellow is there. It can go side, go to the subarachnoid, cannot go to my brain. If the catentious retinoblastoma cells means, that means you have done inoculation what for, man? To treat the patient and cure the patient. Now you have catentious retinoblastoma cell, that means you have not cured him. He needs further treatment, chemotherapy to be given to the patient. In a prognostically very bad. Samjha? Hello?
Yes, sir.
Punch. This is what exam question for you. What's the length of the optic nerve to be cut, doctor? You must immediately, sir, as long as possible, minimum, more than at least 10 to 12 millimeters, sir. What do you do? The cut and I will do for histopathology, sir. If the catentious retinoblastoma cells, sir, prognostically very bad, sir. Because of CRA enters 10th millimeter, the chance is there for the tumor cell would have gone like this to my brain. समझ गया?
हाँ सर.
भूल जाएगा?
नहीं सर.
भूल. Forget me not. Tell me.
Forget me not.
Forget me not, doctor. Solle.
Yes, sir.
Forget me not, doctor. Kunch.
Yes, sir.
This is what done. I told you. Retinoblastoma. Remember? Forget me not, but it can grow in dark, shady areas. It remain hidden for weeks or months. That's why the same happens with your bloody fellow retinoblastomas. If you are not aware, hello, they can go everywhere and person may go vertical takeoff. May go to the upper wall if you're not treating properly. Understand now? Kunch?
Yes, sir.
समझ गया?
हाँ सर.
भूल जाएगा?
नहीं सर, never sir.
ये रेटिनोब्लास्टोमा क्या कहता है? Tell me.
Sorry.
ये रेटिनोब्लास्टोमा क्या कहता है? Hindi correct or not?
Yes, sir. Fully correct.
Very good. Thank you very much. We'll see again. Time permits. I think I'm always available any day if you fix. Even Friday also. Ramya Nandige.
Yes, sir.
Any
Yes,
Friday night I can take a MBBS class also completely.
Okay, sir.
If time
Sure,
permits.
sure. Thank you so much, sir.
I'll be happy
Thank
to
you.
see Dr. Kunch, Pallavi, Neha, and Sumant. They are all coming in my view.
Yes, sir.
Of course, Ramya. Ramya nodding only. Ramya nodding doesn't show her face. Very
Sir,
bad.
one minute.
You are not showing the face. Bloody fellow, sir.
Hello, sir.
Yeah, not angry, no. Hello. For fun.
No, sir. I was in the hospital. That's why.
What a day, Ramya.
Yeah.
Learn well.
Thank you so much, sir.
Retina well. Learn well about retina.
Yes,
And
sir.
of course, future layout to help us.
Thank you so much, sir. We all seek your guidance and blessings always.
Okay.
If I have to summarize this class, sir, I think it was a forget me not class for everybody. I think everybody will agree in me saying that they're not going to forget this class ever and retinoblastoma ever. I deeply thank you for taking time from your busy schedule and conducting this session, sir. I'm sure everybody has enjoyed it. You can all tell your views. Kunj, Neha, Pallavi.
Pallavi, mera beti, you tell better about, hello, you tell something good about me.
Sir, it was a very nice class, sir. Thank you so much, sir.
Thank you, da.
Yes, sir. We really enjoyed a lot, sir.
Enjoyed a lot, sir. It was very interactive and very nice, sir. Engaging class.
Learned a lot.
Yeah,
Thank
thank you very much.
Thanks, Managa. We'll meet again.
Thank you, sir. Thank you so much, sir. Wish you a very happy new year again.
We will meet again.
Happy New Year, sir.
Happy New Year, sir.
Again, sir.
We will meet again. Kabhi alvida na kekhna.
Yes, sir.
Yes, sir. Kabhi nahi.
Kabhi alvida na kekhna.
Yes.
I saw this movie in Jammu Kashmir in 78. Hum kise kam nahi.